My name's Dr. Catherine Henderson. I'm a consultant in emergency medicine at St Thomas's Hospital in London, and have a background in interest in healthcare risk management.
And I'm Justin Cookow, the Head of Business Continuity Management at the University of Surrey. And this webinar is looking at an introduction to business continuity, what it is, why we do it, and the clinical importance of getting it right. So it's always good to start with a definition. And this definition comes from the International Standard for Business Continuity Management Systems, which is ISO 22301. So business continuity is the ability of an organization to plan for and respond to incidents and business disruptions in order to continue business operations at an acceptable, predefined level.
So what does that mean in practice in an acute hospital or an acute emergency system? That means that you need to be able to carry on giving high quality patient care. And you need to be able to respond quickly and recover quickly after an incident. So that would be an internal incident or an external incident. And why does that matter? Why this matters is because it has to be that a hospital is a good place to go when there's a major incident, and a hospital can carry on providing high quality care when there's an internal incident. It's got to be that a hospital is a place of sanctuary. It makes sense to go there. You know that that system will be able to continue functioning, whatever is going on, because your general population view the hospital as somewhere that it's a good place to go. You don't want it to be a dangerous place to go, and you don't want it to be a place that is highly disruptive. And we'll come back to this idea of safer hospitals, building safer hospitals a little bit later on in the day. But that's the core principle, which is we have a duty to make sure that your hospital can continue to run whatever is going on, that you never need to go, we've just got to stop, we can't do this anymore. And yet that clearly does happen quite a lot.
So as Catherine said, business continuity is very much the foundation for emergency response. If we've got no power resilience, then you're not providing emergency surgery to casualties in a major incident. If your communications fall over, you're not sending out alerts to mobilize your staff to come in and respond. So business continuity is a core component of integrated emergency management. And to plan for business disruptions, we need to start with anticipation. So we need to anticipate, assess, prevent, and prepare. So that's visualizing the impacts of disruption and planning for the consequences of disruption. And then in response mode, we need to be able to respond and to recover. And if we've got effective business continuity plans in place, the recovery period will be shorter and the disruption will be less. And a core component of recovery is, of course, capturing lessons. And we're going to spend a lot of time during the course of today talking about the process of continual improvement, capturing the small lessons that come out of the daily interruptions to make sure that when something big happens, you've improved your systems so that you are more resilient. So business continuity is just one of the risk management disciplines. And this diagram shows that it's closely aligned with health and safety, with major incident planning, with fire safety, with IT and disaster recovery, and of course with clinical risk management. So business continuity, so risk management controls most of the causes. Business continuity deals with the effects, the consequences of incidents. And then insurance will cover any issues that are not picked up with business continuity itself. So in your organizations, do you know who is responsible for leading each of these risk management disciplines? Do you have a relationship with them? Do you have emergency planning leads in your hospitals? Take the time when you get back to work to ask those questions, to make sure that you understand who holds the responsibility for these disciplines, and connect your work to theirs so that you are able to build a more effective, a more resilient system. So how does business continuity link to risk? Risk ultimately should be understood specifically in respect to the organisation's critical activities and the risk of disruption to these. So business continuity is not about trying to safeguard absolutely every service. It's about trying to identify what the key priorities are. What are the most critical elements of what you do that keep patients safe? And it's then about looking at those activities and safeguarding them. Hence, in the definition, identifying to predetermined service levels. Okay? So if you've identified what's critical in the emergency department, you know that resus needs to continue irrespective of what's going on elsewhere. Yeah? So you look at the critical elements of resus, you look at the equipment, you look at the staff, you look at the IT, and you make sure that those are resilient to predetermined levels. So you have a minimum service offering for that critical function of resus. And each of these critical activities, as I said, is underpinned by resources. So resus is staffed, it's located in the emergency department, it's supported by IT and technology, and of course by supplies and equipment. And all those elements need to be resilient. So the link between business continuity and risk is all around identifying the risks to those resources. Okay. And if you understand the threats to the resources, so if you understand that your supply chain is weak, if you understand that your IT is vulnerable, that your power is irresilient, then you are able to plan more effectively so that you can continue the delivery of those functions when there is a disruption.
So, how many of you in the room have been involved in 5 or more major incidents? So, train crashes, aeroplane crashes, explosions. Put up your hand if you've been involved in more than 5 major incidents. So, no one in the room has been involved in 5 major incidents. 2? A few people? 1 major incident? A few people in the room saying yes to 1. How many people have been involved in by understanding what an internal incident might be, like loss of power, really bad storm, making it difficult to get staff into work, have been involved in more than 5 of those? Yeah, so more people are now putting their hands up. So the reality is that we're much more likely to experience an internal incident than we are a major incident. And yet we spend a lot of time often talking about major incident planning and not so much time, particularly as clinicians, for the clinicians in the room, may not get involved in business continuity planning. And yet you will actually experience those events much more frequently. So the big things, the external risks, are the things that you need to think about. Those are big disaster type events. Sorry, my noise from this is a bit intermittent. The big events do happen and you do need to plan for them, but you're much more likely to experience something much smaller. So in my last week, we've had a power problem, we've had a staffing problem, we've got the threat of flu epidemic. You know, there are a large number of things that happen often on a daily basis, it feels like. We have the IT system decides to go on strike. The MedChart system will no longer function, and you've suddenly got patients on the wards that you can't prescribe drugs for. All the drugs cupboard lock. We've had power out so that the incubators on the children's ward were no longer powered. So those things happen on a regular basis, and the problem is very often is that as clinicians, I'm speaking specifically to the clinicians of the room, we're not involved in thinking about the consequences. We don't think this is part of necessarily our job to think about planning for this sort of thing. And yet when it comes to a major incident, lots of people are getting excited and involved. Very often, the reality of major incidents is that it involves not necessarily very large numbers of casualties. You know, we've all experienced major events, but actually you've only had a handful of casualties. So in my recent time, I've had a number of terrorist incidents in London. My hospital is at the end of Westminster Bridge, and London Bridge is 2 bridges down from us. These were 2 major terrorist episodes in London. Westminster Bridge, we got 2 patients. London Bridge, we got 8, and they were much more seriously injured. So that was a much bigger event. But those become the focus of a lot of attention as opposed to these minor events. And it's the minor events that you need to plan for. So we would be quite interested in knowing at some point during the day how you respond to issues like getting staff into work when there's bad weather, adverse weather conditions, which you've obviously had quite significant ones of recently, and the plans that you have for that sort of thing. Ditto, when power goes out or IT goes out, what is the resilience in your systems? Have you thought about the resilience in your systems and what you would do when? Simple things like for us, our electronic drug cupboards, we have a key. As long as you know where the key is, somebody knows where the key is, you'll be able to deal with that incident. But unless you're a clinician involved with thinking about the things, you might not have gone through the process of actually working out what it is that you need to do. So the typhoon, we're quite interested in knowing a bit more about your experience of typhoon. Go on, thank you. Those are the sorts of things that having a typhoon would generate. Now, we're very aware that when we look at, say, for example, the advertisements for this course, there's quite clear guidance on whether the course will run or not in relation to typhoon level of warning. And you clearly have plans to think about whether something's going to go ahead. Even your exams have warnings about whether it's going to go ahead in view of a typhoon. But what is it that is actually planned in relation to how you get staff in place? So for an example, in the UK, which can get brought to a total halt by very small amounts of snow, we provide accommodation for staff. And I suspect you will do something similar. And hopefully, as the day goes by, we will learn a little bit more about what your plans in relation to that are. We know that bad weather can cause huge problems with power. And we'll talk a little bit about the examples of some major incidents where power has been one of the most serious problems. But certainly in Hong Kong, during the recent typhoon, there were examples where hospitals had problems with their power supplies and had to go on to backup supply during the time that the typhoon was going on, and how that worked. Getting staff into work is always an issue. If you're running an emergency department and your critical function is to continue to run that emergency department, you need to be assured that you're going to have sufficient staffing, and you need to have staff for the next day as well as the day that you're dealing with immediately, so that you haven't ended up with all your staff in at one point and then no one for the shift that's taking over. And we'll talk about flooding, because flooding is one of the most interesting incidents, particularly where it related to New Orleans and what happened to the hospitals there. But I'm sure flooding, again, for the typhoon is quite a problem. Moving on.
So in exactly the same way with a typhoon, it's entirely possible to visualize the impacts and to foresee the consequences that Catherine's just described there. It's the same with IT. You can visualize the impacts and plan for the consequences of IT not being available. So when IT does fall over, and we'll touch on this in this afternoon's webinar when we look at the impacts of the WannaCry ransomware on the NHS in England, where essentially all of that stuff on that slide was unavailable in some of our most significant acute trusts, including our major trauma centre. It's pretty scary from a patient safety perspective, right? And as clinicians, it's really important that you've thought about what happens when IT falls over. You've thought about what the workarounds look like. We're all so dependent now on IT that when it falls over, do you have paper forms that you can fill in? Do you have alternative access to systems? Do you have arrangements in place with your suppliers to help you bring back IT which they are responsible for providing? And if you've got these workarounds in place, have you taken the time to train up all staff, not just your core staff, but any bank or agency staff that are coming into your hospital and working alongside you, so that on a random Friday night in A&E, which may potentially be staffed by agency staff, if it's then and it's busy and your IT falls over, are they going to be comfortable and confident to respond and follow effective business continuity arrangements? Okay. So, is there any difference between business continuity and emergency planning? We've already established that internal incidents, business continuity incidents, are likely to be more common and more impactful than major incidents creating lots of casualties. And actually, whilst lots of senior clinicians may want to get involved in a high-profile major incident, when it comes down to taking down your IT system for routine maintenance, it's a lot less interesting. But actually, potentially, it's a lot more impactful. Yeah. Ultimately, the consequences of a major incident and an internal incident can be very similar in terms of the ability to deliver services. Yeah. A major incident, if it's associated with adverse weather, may well take down your power. It may well lead to flooding of a basement. But actually, just as likely are configuration problems with your power, a UPS failure in your data center, a leak from one of your toilets over a key piece of IT equipment in part of the building that's been poorly maintained. Yeah. So it's similar people that are involved. Yeah. And ultimately, it's largely similar skills as well. Okay. What's really important with business continuity planning is that your external interfaces are also considered. No hospital is an island. No hospital can deliver its services on its own. It's entirely dependent on the ambulance service, on utility providers, on transport providers to get your staff into work, on your key suppliers so that your equipment is maintained and serviced. Okay? And for major incident response and internal incident response, you will almost certainly use the same capabilities. So you'll use the same control room, you'll use the same critical communication systems to alert staff as to what is going on. Yeah? So the point I'm trying to make is that ultimately, business continuity and emergency planning are two completely interlinked disciplines. Okay? And to have effective emergency planning, you need to have effective business continuity planning.
And we will keep emphasizing this. Internal planning, you can actually end up disrupting a lot more patients by these incidents. So when power goes and you have to cancel theatres for 3 days for some reason, you can end up with many more people who are at risk of problems than you might have done from a single major incident. So internal incident, major incident, we've said the principles are the same, but actually there tends to be less resources paid to the internal incidents. Tends not to have so much focus, and yet reputationally particularly an organisation can be much more harmed by internal incidents that don't go wrong, right, and financially also can be actually much more destructive. So while it involves often the same people, you will often find that people appear in a major incident that you've never seen before in your emergency department. It's the first time they've come visiting and they think they're going to run it. We discovered that our orthopedic surgeons had put themselves down as running resus. We weren't very sure that that was an entirely good idea, since the orthopedic surgeons had probably never physically been in the resus room until the day that they thought that they might be. We did a bit of editing of their action card rather rapidly. And that's another point, is actually making sure that staff are familiar with your organisation when events happen, and using these as opportunities to practice some events. So it's possible to actually get quite a lot of good information about how a major incident will run by feeding back to a wider audience than you might have thought necessary about internal incidents. So you take the lessons of your internal incident and you make sure that they go to people who you might not have thought would have been on the list of needing to know what happens. And the reason for that is that if you can do these minor incidents well, if you're really slick at dealing with the lifts out in the North Wing, you're really good at working out how you're going to move patients around. When there's a fire, when there's a major incident, you actually may do an awful lot better. It will help you perform well in a major incident. And a very straightforward example of that was Thailand in the tsunami. There was a hospital that had done a lot of emergency preparedness practices and drills for major incidents and also for small incidents. And when the tsunami struck, that hospital wasn't damaged, but it had vast numbers of people come to it. But they were able to deal with communication issues, how they were going to manage the floor space, how they were going to manage a lot of their services extremely well. It was felt that their degree of practice, both for serious emergencies and for more minor events, made them perform a lot better than they would have done. And we know that's true generally. So if we haven't sort of said it enough, it's all about making sure that your institution can carry on doing its core business, whatever is going on, that you will be able to have the capability in a major incident, and you'll maintain your capability in the face of those minor things that go on. And I get the impression in the room that IT is striking home. There's a lot of people smiling at the thought of bits of IT systems not working quite as they'd like it to work. And we often deal with those sorts of things on a daily basis.
So we'd like to get you to spend a few minutes thinking on your own and using the post-its on the tables as to what business continuity means to you. So think back over the last 12 months perhaps about any disruptive incidents that have impacted on the operational performance of the hospital, okay? So identifying internal incidents, and then what we'd like you to do is to identify from the categories below which of these incidents had the primary impact on people or premises or utilities, IT or telephony, or supplies and equipment. So what was the main impact from each of these incidents? So using the post-its on your tables, please, write out a list of which incidents, disruptive incidents you've had in your hospitals, and we'll come around and gather those and then put them on the relevant flip charts in just a minute.
So while you're doing that, just because we want to be able to keep the audience online amused as well, thinking about people incidents that I've experienced, or planning for people incidents. Probably one of the most serious ones last year was thinking about flu. Were we going to have enough staff to be able to manage patients if we did have a flu outbreak? And obviously flu last year was fairly significant. Around the world, there were a lot of cases of flu. Do keep writing. Justin's going to be coming round to pick up your bits of post-it note. But there needed to be projections made on how many staff missing would make it still possible to run the services that we needed to do. This winter, we're looking at, because we're heading into winter in the UK, we're looking at infection control incidents in terms of our being able to manage our premises and how we have beds available for patients. One of our local hospitals had 120 beds closed because of a norovirus outbreak. That puts an enormous strain on the rest of the hospitals in the area, so we want to think about how that's going to work. In terms of IT, I mentioned that we'd had problems with systems shutting down, or sometimes routine maintenance that goes on a lot longer. And one of the issues with IT systems for emergency departments is that we don't stop. And that will be true for all emergency services. If you're trying to deal with something to do with the outpatient's IT system, it's fine. They can do something overnight and everyone's happy. But people forget that emergency services are 24/7, and it's a significant issue if you've got a backlog of 30 patients to enter onto your system because you've been down for half an hour while routine maintenance goes on. So that will be an example of IT. And then supply issues have related in the UK, but also internationally, to access to diamorphine, to access to ciprofloxacin, and to some strengths of ketamine, where there actually have been drug supplies that have not been available. So there are these little incidents that happen that you have to have a plan for what's going to be the alternative if you can't access what you think is your primary drug of choice in that sort of situation. So all of those things can have an effect. So Justin, do you want to go around and see if we've got any examples that we can use? And we'll put them. And if you think about, for the rest of the day, think about how business continuity affects these individual areas, so that when you're doing planning, you can actually cover all 5 of the areas that are most important for thinking about business continuity and the impact of an episode. So the first one that's on the screen there is about difficulties in getting people into work when there are transportation disruptions. I mean, that's certainly something that can happen in any country where there is a significant event on the transportation system. During the typhoon, obviously there must be a transportation, elements of the transportation being shut down. And presumably there are plans to get staff to work. Can anyone give me an example of what plans are made to make it possible for staff to get into work? And I'll give you the microphone. Or are there no plans? There are no plans. I'm being told from the back that there are no plans. So that's interesting, given that it's kind of predictable that you're going to have adverse weather conditions. The expectation should be from business continuity planning that there is a way of communicating with staff with a prediction of weather and an expectation of certain behaviours. So for my own hospital, adverse weather conditions are not considered a reason for not getting to work. There's a rather firm message that goes out, which is there is going to be snow. It's likely to cause travel disruption. The expectation is that you make plans about being able to get to work. We, as an institution, will make it possible for you to have accommodation for the night if that works best for you. But the expectation is that you come to work, that you make arrangements which mean it's possible to come to work, rather than turning up at a station, there being no trains, and then phoning in saying, I've turned up at the station and there are no trains. That's not considered acceptable. Now that's in a sense that is business continuity planning. That is saying we're going to warn our staff that the expectation is that you come into work rather than that you don't come into work. But there has to be a sort of second level to that, which is in the situation of snow, and I suspect this works in typhoons as well, schools get closed. And given the workforce that is often working in emergency care, people have young families. And so they may well discover that the school that they're depending on to look after their child during the day is no longer open, and therefore they've got massive childcare issues. But again, with a bit of advanced planning and the technology that exists around the weather these days, there can be an expectation that some planning goes into that. So you're giving an element of responsibility to your staff. And what's important is you're not doing it on the day. You're not saying to them, but for heaven's sake, you could have organized this better. You're doing a plan in advance so that you have an adverse weather plan that's in your business continuity overall plan that says these are the expectations. We will get information out to you that there's going to be adverse weather conditions. And these are the things that we expect you to do to make it possible for people to come to work. And the chances are, if you do that, you will end up with a lot more staff in than you would have ended up if you hadn't done any planning at all. So I'm going to go over to premises and see what we've got here. So definitely the typhoon is featuring in terms of a great one, of typhoon having caused power suspension and somebody trapped in a lift for 2 hours. So lifts and power, very difficult with lots of buildings these days that are very high and they're very dependent on using lifts to move people around. I think everyone will have a story somewhere of someone getting trapped in a lift. That's fine if that is just a man trapped in a lift. What's not so great is if it's a patient coming down from the helipad who's a major trauma patient. That has happened. Or it's somebody being moved between theatres and the intensive care unit. Or it's a patient who needs to go from your emergency department to intensive care or theatres. So does anyone know how their lifts function if there's no power? How did the man get out of his lift? Whoever made that suggestion. Who wrote that one? How did they eventually emerge? Right. And so it wasn't a patient, it was fortunately somebody who was well. So the business continuity planning was risk assessment of the needs of this individual, and the needs of that individual were far behind many other people's needs, and so nothing happened. However, I happen to know when we had a power outage very recently in our high north wing, that the generators come on, so there is power, but the lifts go off because lifts take a lot of power. So if you're on backup power, you don't want to be running your lifts. However, you still have the capability of turning on lifts to run off your generator power if you need to. So you don't let people just go up and down in them, but you have them in an emergency possibility of turning generator power back on to make your lifts work, which means that you can, say something really bad happens on the 7th floor, you can get somebody out. In addition, most lifts will have some sort of hand crank type device, which means you can get to one floor and then force lift doors open. But knowing that is useful, to actually know that that isn't the end of the world. You can actually do something when power has gone out and your lifts have gone.
Fantastic. So lots of really great examples in the room. Thank you very much indeed for those. And during the course of the day, we'll come back to these examples and look to explore them further. So I note under supplies and equipment, there's the China vaccine scandal, which I'm keen to understand more about. IT and telephony, I know that there are lots of nods around the room when we talk about the impacts of taking down IT. And premises and utilities, Catherine's just talked about lifts. And people, well, we've got a long row of post-its here, primarily associated with the typhoon, but also looking at the impact of staffing when there's flu. So how do you surge your staff to deal with flu at a time when potentially your staff is disrupted because they've either got flu themselves or because their dependents have got flu, so children at home, schools closed, and the likes. So let's move on now and look at, now we've understood what business continuity is and had some really solid examples from you as to what type of disruption that causes, as to the why. So why do we do business continuity? And there are three key drivers: business drivers, governance drivers, and legislative drivers. And I'm not going to spend ages on this. I want to go through this relatively quickly. But it's really important to contextualize why it is that we do it. What are the primary reasons for this? So from a legislative perspective, what are the legal requirements on you as hospitals to have business continuity planning in place? From a governance perspective, do you have standards that you need to meet? And from a business perspective, clearly there are moral imperatives, but also financial imperatives and reputational imperatives for getting business continuity right. So taking each of these quickly in turn in a UK context. From a legislative perspective, in the UK, all acute hospitals are what are described as Category 1 responders under the Civil Contingencies Act. And as a Category 1 responder, there are a number of core duties that an acute hospital trust has to have and has to deliver against. So in addition to doing risk assessments, business continuity arrangements are a requirement in law for acute hospitals and other emergency services and Category 1 responders in the UK. So other Category 1 responders include the Environment Agency, the Maritime and Coast Guard Agency, and of course, emergency services, fire, police, ambulance. From a governance perspective, the NHS in England has emergency preparedness, resilience and response standards. And business continuity planning has to be aligned to each of the standards, and those standards are audited against by NHS England on an annual basis to make sure that you have indeed got in place what you say you got in place. And part of the evidence requirement is that you've tested your plans to make sure that staff understand them, that the assumptions are understood, and critically, that the plans work. There's also an expectation that once you've tested your plans, or you've had an incident, that you've debriefed and you've learnt lessons to further improve your plan. And UK healthcare organisations are now required by NHS England to align to this international standard for business continuity management systems, ISO 22301. Have you come across this standard before? So, looking around the room, this is a new standard for people, and it's a standard that sets out what a business continuity management system looks like, and we will, during the course of this afternoon in particular, go into more detail about how you build a management system and how you build an effective, continuing improving learning process to make sure that you've got those effective plans in place. So, very briefly on ISO 22301, it establishes the processes and principles and the terminology around business continuity management, and it provides the basis for understanding and implementing business continuity to ensure that organisations have confidence in dealing with, in our context, patients and indeed other organisations. Okay? And the importance of an international standard is that it means that management systems are built in a consistent and effective way. So it's a repeatable process. It's not good luck that John happened to be on a Friday night and knew something about the plan, or that they were in a position where they were able to respond, but actually it's because it was part of their induction, it's part of their job description, they've been involved in tests, they've reviewed the plan, they've been involved in incident debriefs to make sure that they've learnt the lessons from previous disruptions, okay? And the core standards in the NHS are, as I say, they're annually audited, and the expectation of an emergency planner like myself, when working in an NHS acute trust, is that having finished the assurance process with NHS England, I need to then write a statement which is then approved by the board of directors to say that this is where we believe we are in terms of our own self-assessment of preparedness. Okay? So the board takes ownership of how effective business continuity and emergency preparedness is within the hospital setting. And that's really important. It's all about leadership from the top and ownership from the top. And this rarely rather scary long list of documents is what you need to put in place to gain certification to an international standard. I've recently done this at the University of Surrey, and that's what my filing system and electronic system looked like to prepare for 14 days of external audit. So a quick note of caution. Standards are fantastic, but they also bring with them lots and lots of documentation, lots and lots of work. So you need to be really clear about what the benefits are before you go down the route of formal certification to a standard. And that's why the NHS in England requires healthcare settings to align to the standard rather than certify to the standard. So the expectations are there, but you don't necessarily need to have the full shebang to achieve certification.
So as an organisation, the other part of this, so that's all sounds quite scary, and that's why you have an emergency planner. You need to have somebody who can understand what you're trying to work towards in terms of the standards. But as clinicians and management people who are involved in emergency services, there are some very real things about this that matter. We're interested in patient care. We absolutely want to be able to continue to do patient care. So there is a patient experience, a patient outcome aspect to business continuity that is absolutely critical. And when we talk about the IT failure, the ransomware failure in the afternoon, WannaCry, you'll see how much that did actually affect patient care. It really matters. And therefore, as frontline people, we need to be aware that this has an effect on patient safety. It absolutely has an effect on patient confidence in an organisation to deliver care. It also makes business sense to not be paralysed by a relatively small incident, because you can find yourself with a backlog. It doesn't take much. If your theatres are closed, your blood bank is closed, or something has happened, for you to have a backlog of patient care. And you're playing catch up for a long time to come. So from a business point of view, that maybe that's how your contracts work, you've got to be able to deliver a certain amount of care. It's not a good idea to fall behind with the work, because to be absolutely honest, we're all pretty busy. We don't have a lot of excess capacity to deal with something that we didn't do a few days ago. None of us, I suspect, in the room have got spare capacity to make that possible. And also, actually doing business continuity helps you spot things that are not working right in your system. So we're all committed always to continuous improvement. What does that actually mean? Well, continuous improvement in terms of business continuity is to make sure that we learn the lessons of incidents. Because actually, if you don't learn those lessons from incidents, it's really hard to say that you are committed to continuous improvement. Something has gone wrong. Power has gone. The baby's incubator no longer received power. That's something you're really going to need to do something about pretty critically. But it makes people rethink. What had happened there was that the incubators were not attached to the continuous supply. In other words, when the main power went down and the generator power went up, generator switches were on that side of the room, the incubators were plugged in on the other side of the room. Not a particularly difficult one to fix, but it makes you think about what was going on when people were putting those incubators in, where they were placing them. Were people thinking through actually all the events that could happen and why did it matter? So incredibly important that when something has happened, it's fed back to a large number of people. But it makes business sense to have this going. Financial sense, reputational sense, and actually how you can kind of plan what you're going to be doing. And we know plenty of things. We've given lots of examples already. We're going to talk about WannaCry in much greater detail. But most places will have had an IT incident. So let's play that game again. We've got people who've put things on there. How many people have had, within the last year, some sort of IT failure or breakdown? Experienced that? Stick your hands right up so we can see. Yeah, so there's somebody at each table, if not more than one person at each table, who has experienced some sort of IT event. IT systems need updating. So you need to have planned out times from IT systems. So you've automatically got built into what happens on a daily basis an outage, but it's a planned outage. Now, if you make the most of those upgrade outages to learn from what happened, when it happens unexpectedly, you tend to do better. As an emergency consultant, leader of the department, I'm always insisting that any IT upgrade gets done between 5 and 6 in the morning. Really annoys the IT people, telling them to come in at that time, because actually that's when we're least likely to have large numbers of patients booking in. They always want to do it at 8, but 8, the day is just ramping up, and it's the last thing you want is to be doing it at that point. So timing is obviously one thing for the planning, but you also want to just make sure that there aren't knock-on effects that you hadn't anticipated. So it's useful to go, are we going to do paper versions? How are we going to backdate and get the people who didn't get registered, say, into the system, onto the system? How am I going to plan for my staffing, for my admin staff, to do that? And doing that on a very small scale, something that is maybe only a couple of hours, will make you think better about what you need if it happens in an emergency, and then you can have planned for that. We've talked about power failure, water contamination. We had a phase where we had mixer taps, and we were told that having had them for 7 years and we'd all drunk from these mixer taps, that was no longer suitable for patients. We had to then get water systems that we had supplies of water available to the hospital in bottles for everybody. But at an even greater scale, post New Orleans, and we'll talk about the New Orleans experience quite a lot at various stages, one of the issues was that despite the fact that these hospitals were surrounded by water, flooded basements, they didn't have water for staff and patients, actual water for staff and patients. So the new Southern Louisiana major center, a hospital that they've now opened as a rebuild, a new build, involves a rooftop water collection system of rainwater, which can provide them with a lot of water if they should need it. They've also built into their system 5 days of independent water supply in tanks, so they could survive 5 days of clean water. But in addition, they've thought about the build and what they could put on the roof. Bomb threats are interesting ones because you can paralyze a hospital very quickly on security, on a security concern. And obviously in London, that has been a major concern to us. We now can shut down our hospital in 90 seconds. So that means every door is closed and has somebody by it within 90 seconds, which makes it very much easier to control the site. So it's useful to think about that sort of thing. What would happen if a live fire incident happened in your emergency department? How would you control that not leaking to the rest of the hospital? How do you make sure that that happens all right? And that's something that you can think about and plan for even when there's nothing much going on. We've talked about lift failure. We've talked about infections. We also had a very interesting one when our junior doctors went on strike. That was a bit of a surprise. First time in the beginning, ever since history that junior doctors went on strike. But we at least had advance warning of it, and you could do some planning. But it gave us a very interesting example of what it would be like to run a hospital without large numbers of staff. I'm afraid to say it really worked rather well. Consultant to consultant referral worked to treat. Nobody argued, and we were all frightfully pally. Whether that would have been true, a week down the line, I'm not so sure. 24 hours was enough. But you can imagine that thinking about if you're missing staff is an important thing to do, and I'd be very interested in the thoughts about the typhoon and what happens there. And then we've already mentioned that there can be issues with drug supply. So we know that these things happen. These are incidents that you can look back on. You can look at the lessons that were learnt from them. You can then make sure that you have got fixes in place that would mean you wouldn't fall foul of the same problems. In addition, you can look at your own incidents and make sure that you've got the learning from them. So some things are planned. They constitute a major incident, but they don't constitute a major incident in the sense of overwhelming your resources, assuming that you have planned for them. So I mentioned that my hospital is at the end of Westminster Bridge. The end of Westminster Bridge and around something called the London Eye is the focus of London's New Year celebrations. So there are hundreds of thousands of people packed into a fairly small area, all staring at the sky for, about 11 minutes, and then the rest of the time moving around and drinking and talking to each other and falling over. There's huge crowds. There's a lot of a lockdown of the area. And as the years go by, I think this is getting more and more organized from the hospital's point of view. But it is something that you can absolutely plan for. And I would assume you would do the same for your various New Year or major event celebrations, that you will plan for what does that mean for your staffing? How are you going to get staff in? How are you going to deal with the inevitable transport delays that there are? You're going to change rotas so that people are leaving and coming at more reasonable times, make it easier to do. You'll have security issues, and you often find in this sort of situation that mobile phones don't work so well. So my hospital builds a fence right round the outside of the hospital. We're really very much in the heart of this event. But we end up with a large fence all the way around the hospital that can be put up in about a day and a half. So they start doing it in advance so that there is only access through prescribed routes. They know exactly where people are going to be accessing the hospital. That's something that you can plan for if you know that that sort of event is going to happen. So it's not really a major incident. It's a business continuity plan. We know we're going to be busy. Basically, the 1st of January for us is the busiest day of the year. We know that we need to staff for that. We know that we need to have extra loo rolls in our public loos because there's going to be a lot of people coming through the system. We know that we're going to need to be able to feed large numbers of people. We can make a plan in advance. And that's a good example of planned business continuity in motion. It's not a major incident. This is not abnormal because we know about it and we can plan for it, and there'd be no reason to not plan for it. So as I mentioned, this is our alert system. This is what goes out. I will get this on my mobile phone telling me, happened to be at 3 in the morning and I was at home and I wasn't terribly interested, if I'm absolutely honest. But the idea is that we have a way of contacting all our staff so that people are aware of what is going on. It was affecting our north wing. We have our elderly care wards, our orthopedic wards, and our maternity unit, along with a lot of biochemistry and microbiology services, so specimen handling on those floors. And obviously it has lifts that go up there. But when you see something like that, you think, well, does this have any effect to me? This is the 7th floor. So if you're an emergency department person, why does this matter? What might matter about this sort of event? Anyone got a thought as to what would be something that was potentially a problem for the emergency department? So one of the first things that was a problem was admitting patients to the ward. There's a number of wards that we admit to from the emergency department on a regular basis, which we now potentially could no longer get patients up to easily. Now, I've mentioned that we could activate a lift if we really, really needed to, but at this point, they didn't know how long the incident was going to last. The patients are entirely safe where they are. We didn't need to move them. There was no clinical reason to move them. This wasn't moving to theatres or ITU. But those were in different blocks. You need to think through what it is. So this is this issue about thinking about external interfaces. It's not a very big external. It's not very external. It's not external to the rest of the hospital. But when anyone is thinking about their incident, they need to think about who else it might affect. What else might be the knock-on problem from this? we don't, very rarely would admit a baby to an incubator from the emergency department. It's not that sort of baby admission unit. This is immediately post-delivery type babies. So that wasn't going to affect us. But the issue of admitting a care of the elderly patient to the ward was one. So when these incidents happen, whoever your emergency planner is needs to think about the clinical aspects of the knock-on effect and think about the interfaces with other services.
Okay, so we've looked at what business continuity is, why it's important, why we do it, and the clinical impacts if we don't do it. So just to wrap this session up, let's just work through what the benefits of BCM, business continuity management, are. So firstly, risks and impacts are better understood and the consequences are planned for. So the New Year's Eve example, you can foresee the impacts and you can plan for the consequences. You can also invest in key areas of risk. If you know that you need to do maintenance on a particular building, otherwise it's going to lead to leaks over your IT server room, then you can identify that early on and make sure that investment is there and that the work is carried out so that you don't end up with an unplanned disruptive event. Effective business continuity management means that plans are put in place that people understand and are familiar with. So there's confidence in response. So that when these things happen, people can go to a playbook and they know what their roles are and they know what's expected of them. You're not making it up on the hoof. And as a result, when incidents do happen, and internal incidents, as we've established, I think, happen frequently, then response is improved. Disruptions are minimized and recovery is quicker. That's good for patients, it's good for staff, and it means that any consequential losses are also minimized, which is great for the reputation of the hospital. And effective business continuity management means that learning from incidents drives continued improvements, and it means that staff grow in confidence so that a junior doctor on a Friday night in A&E who's new to the hospital doesn't feel completely on their own at 3 o'clock in the morning. They feel like they're part of a managed system. And it's this accumulation of small improvements that means that when big incidents happen, as we've discussed, that response performance is significantly improved. So business continuity is the foundation for effective major incident response. So we've got a clear message here. Risk assess and plan. So to summarize, internal incidents are much more common than major external incidents, and internal incidents can well involve large numbers of patients and staff. And as I've said, if you don't plan, recovery will take longer. So, to summarize this session, ultimately, hospitals are places of sanctuary and safety, and having effective business continuity plans in place helps to keep them that way. So thank you very much.